Yes, in this the sulfasalazine we can mainly see the several drugs like in the sulfasalazine the second line drugs. Okay, and the mainly the side effect is that the patient have the neutropenia and the thrombocytopenia, and we can avoid in the patient like G6PD patient. Okay, and in the last we can also study about the leflunomide and also hydrochloroquine. And this leflunomide, mainly this leflunomide is what it is normally a what the pyrimidine synthesis inhibitors, pyrimidine synthesis inhibitors, and it is mainly avoided in what if you give this leflunomide, the patient may have the problem like diarrhea. It has the diarrheal problem. Okay, and also the patient have the problems like the rash, and sometimes the patient may have the reversible alopecia, and this leflunomide is mainly hepatotoxic. Hepatotoxic effect, and mainly they are contraindicated in what perimenopausal women. Okay, female. And at last we can also study the hydrochloroquine, and this hydrochloroquine is mainly used in what triple therapy. And in this triple therapy what we use, mainly you use methotrexate, sulfasalazine, and this hydrochloroquine. Okay, MSH. Okay, we can use this in the triple therapy. And in this triple therapy, like mainly the most common side effect is what it can leads to several the factors like it can lead to the loss of the vision, and this loss of the vision is due to because this drug is what retinal, it shows what retinal toxicity, and this retinal toxicity leads to loss of vision in the patient. Okay, and this is the most important point. That's why you should avoid this type of the drugs if the patient have any this type of retinal problems. Okay, and in the next section you can study about the others like the Janus kinase inhibitors, and these Janus kinase inhibitors mainly the drugs like tofacitinib and the baricitinib and also upadacitinib. And in these drugs mainly used in these Janus kinase inhibitors mainly used in refractory form of rheumatoid arthritis. Means when you can use this type of the drugs like methotrexate does not work, you can use this type of the drugs like Janus kinase inhibitor you can use. Okay, and we can also use the biological DMARDs, or in which we mainly use the TNF inhibitors, and in these TNF inhibitors we can mainly study this etanercept, infliximab, adalimumab, and the golimumab or the sertolizumab. And in this condition mainly if you can give this type of the drug, the chances of what or the risk of increase the risk of several diseases like the several bacterial or the severe bacterial infections and or several granulomatous disease may be precipitated. Okay, during the treatment with what TNF inhibitors. Okay, and also some of the drugs like abatacept mainly it is responsible for the T cell co-stimulation. Okay, it is responsible for the T cell co-stimulation. And the rituximab is mainly responsible for what? It is the monoclonal antibody which is mainly responsible for the depletion of what? Depletion of B cell. And the some of the drugs like the tocilizumab and the sarilumab, and these are the mainly drugs which are normally interleukin 6 inhibitors, receptors blockers or the inhibitors. And these drugs like abatacept, rituximab and the tocilizumab and the sarilumab, these mainly drugs are used in the rheumatoid arthritis in the severe form or the severe or the refractory condition. Okay, and that's all. And these all are about this DEMRADS or the several other features. And in the first part you can study about the rheumatoid arthritis clinical features and the some signs. You can revise this topic. Okay, in the introduction we can study this polyarticular joints, more than 5 joints in involvement, and it is the chronic form. Means what do you mean by the chronic form? The chronic form means more than, the problem is for more than the 6th month. Okay, and mainly involve the MCP or the PIP or the wrist joint, and mainly spare the DIP. Okay, it is the autoimmune. And some of the articular signs like inflammation, pain or stiffness may be there, bilateral symmetrical involvement, and the morning stiffness more than the 60 minutes. And the symptoms mainly resolves on the activity or the and mainly the polyarticular, and main hallmark features is the flexor tenosynovitis. Okay, and the some signs like the Botnier signs, and the also the patient may have the swan neck deformity, and the mallet signs is there, and jet form deformity is also, and the several ocular manifestations and the other manifestations like atlanto-occipital joints involvement may be there, and also the most important Felty syndrome. And what are the included in the Felty syndromes we can study, and also you can see the extensor rheumatoid nodules mainly seen in this condition. And the several lab diagnosis, the most important is the anti-CCP, which is mainly seen in this condition. And also you can go through the treatment, and main aim of the treatment is what? To decrease the inflammation and the preservation of what? The function, and prevent erosion. Okay, and for this you can give the corticosteroids or the prednisone, and sometimes we can also give the main treatment, or main treatment is the synthetic DEMRADS, and in which we mainly give the methotrexate. And what are the steps taken, or what are the investigation can we do for the starting of the methotrexate? You can go through the several protocols, or the you can go through, means mainly go through the protocols, and also the sulfasalazine and leflunomide and the hydrochloroquine. Okay, and genus kinase inhibitors, and sometimes biological like the TNF inhibitors, and abatacept and the rituximab and the tocilizumab and the sarilumab. Okay, thanks for watching, and please do subscribe and like my channel and share with your